My name is Dr. Stephanie Archer. I'm a health psychologist and researcher, and I work at the University of Cambridge. The project I work on is called CanRisk, and I'll tell you more about this later on. There are around 55,000 new cases of breast cancer every year in the UK, and about 7,500 new cases of ovarian cancer. We know that many of these cancers appear in a small group of the wider population who are classified as being at high risk. So being able to identify people who are at high risk is important so that we can help prevent cancer through things like lifestyle change, medication, and risk-reducing surgery, and find cancer as early as possible through screening. A person's risk of cancer has traditionally been assessed using family history to look for patterns across multiple generations of the same family. I'm sure we all know of examples where many members of the same family have had the same kind of cancer. When we're able to see these patterns, we can look at someone's DNA through genetic testing in order to see whether they have a mistake or mutation in their genetic code. If someone does have a mistake in one of the genes linked to cancer, it may result in them being at higher risk of getting that cancer at some point in their life. Using these techniques has helped us to identify lots of people at high risk of cancer, but we would always like to be able to do better. So over the last 20 years, the scientific community have been trying to identify more accurate ways of identifying those at high risk. We now know that family history and genetic mutations play a large part in cancer risk, but that other factors are also important to consider. Research within the group I work in, led by Professor Anthony Antonio, has identified a whole host of things, we call them factors, that are related to cancer. The diagram shows some of the factors that are related to breast cancer, and many of these are shared with ovarian cancer. We can see from the picture that breast cancer is multifactorial. We know that if we can collect information about each of these risk factors and put them into a risk model, which is a fancy mathematical equation, we can more accurately predict who will get breast cancer in the future and who won't. So how do we know that combining these pieces of information helps us better identify people at high risk? Well, we use data from people who have had cancer and not had cancer to see the patterns. It takes information from hundreds of thousands of people to see the patterns clearly. So data are drawn from studies all over the world so that we can get big enough numbers. However, the majority of information that comes from people with white European ancestry. This means that risk prediction models may be less accurate for people from other countries and ethnic groups. This is a problem we'll need to solve, and I'll come back to this at the end. So we know the factors that contribute to cancer, and we know that if we have accurate information about these from patients, we can predict their future risk of getting breast and ovarian cancer. However, we needed to find a way to collect this information from patients and put it into the risk prediction model. In answer to this, we developed CanRisk. CanRisk is a risk prediction tool that can be used by healthcare professionals to predict future risks of breast and ovarian cancer. There are several breast cancer risk prediction tools used in the UK, but CanRisk is the only CE mark tool which has been approved for use in clinical practice. And since receiving its CE mark in early 2020, clinicians across the world have conducted over 300,000 risk calculations. This is what CanRisk looks like when you log in as a healthcare professional. Each of the blue lines relates to one of the risk factors we saw in the diagram earlier. When you click on it, it opens up to reveal a range of questions linked to that point. So here we can see the types of questions that are asked from patients in terms of demographics. And here we can see how healthcare professionals collect information on family history and draw family trees. Once all of the information has been collected, the risk can be calculated, and the tool shows the healthcare professionals and patients the risk in a range of different ways. So we can see here it's presented in words. We also have graphs that we might have been familiar seeing at school. And we also present it in a different type of graph, which we call an icon array. So whilst CanRisk is regarded as one of the best risk prediction tools in the UK, there are some limitations. One that is pertinent to the discussion today is that we can see it only uses English to collect and display risk information. This undoubtedly makes it more difficult for those who have limited proficiency in English to give and receive risk information, ultimately leading to inequality. So we've been awarded a further 5 years of funding from Cancer Research UK to continue our work on developing and testing the CanRisk tool. So in the next 5 years, we plan to identify and incorporate data from people from a range of countries and ethnic backgrounds, for example, those that don't have white European ancestry, in order to diversify the risk prediction model and make it more applicable to our wide community. We also need to translate the CanRisk tool into other languages to make it more accessible for those who have limited proficiency in English. Whilst I focus on these 2 points here, I'd also welcome any suggestions on how we can improve our tool for use within a wide range of populations across the UK.